Hey guys, it's Dr. Linville back here. I'm going to talk to you today about whiplash-associated disorders. Not too long of a lecture, so let's get right into it. These are also commonly referred to as WAD injuries or WAD injuries. The role of PTs in the intervention and treatment of whiplash has increased drastically in the past several years. This was an injury, the term actually, whiplash, was coined in 1928 by American orthopedist H.E. Crow, and he defined it as the sudden acceleration-deceleration force on the neck as well as the upper trunk as a result of external forces exerting a lash-like effect. Another definition here from the Quebec Task Force defines whiplash as an acceleration-deceleration mechanism of energy transfer to the neck, which may result in bony or soft tissue injuries, which may lead to a variety of clinical manifestations. I think it's important to look at both of these definitions, but I like the Quebec Task Force definition just a tad bit more due to their inclusion of orthopedic and neurological reference here to bony or soft tissue injuries, but the statement of variety of clinical manifestations opens itself up to some of the neurological conditions that may be associated with whiplash, and we might in a little bit here dive into the kind of the association between whiplash and concussion and some of the things that are common in both. So for a whiplash, what's the mechanism of injury? As we can see, our friend Eli Manning over there has probably gone through this scenario several times, and we can see he has been forced into hyperextension in typical Eli Manning fashion is fumbling the football. So anytime external force is delivered to the trunk while the trunk is stabilized, this is how the mechanism of injury is created. This can include, and probably the most common is motor vehicle accidents, but also sporting injuries, excessive pulling on or thrusting on the arms, falls or landing on the trunk or shoulder, which is also a big reason we want to prevent falls in our clinic because they could sustain neck or head injuries as well. Motor vehicle accidents may be the most common. Over 1 million whiplash injuries occur in the year in the USA, and then 18% of those are rear end impacts, so the patient typically never sees it even coming. They can't brace to stabilize their neck or anything like that. It's just bad news. So head position and amount of force, do they matter? And is one better than the other as far as predicting which patients get better or which patients have longer injury? So most WAD injuries involved forced combinations of motion. Flexion or extension force is applied to an already rotated head. So if you can just picture someone sitting in a car at a red light and they turn and look at other cars crossing the street, or there's someone spinning a sign on the at the stoplight and they're watching them spin the sign really cool, and then they get rear-ended. So their head's already turned looking at something else, and then they go into this extension and force flexion moment, which creates almost like a three-dimensional axis of rotation, and it leads to increased injury. Head position is the only clinically significant correlation with symptom duration, and there's a study that came out that showed 57% of people sustaining whiplash injury with symptoms persisting at least 2 years state having their heads rotated out of the anatomic position at the time of the injury. So that can tell you that almost 6 out of 10 patients, if they sustain a forced combination of impact, that their symptoms will probably last much, much longer than someone whose head's in neutral position. As far as force goes, there's no threshold force that will guarantee a whiplash injury, and I think some of the reason is because there's not a lot of candidates that are going to be volunteering for studies to undergo force distribution through the neck to try to get to a threshold for whiplash. I can tell you in the concussion world, there's basically they put accelerometers in these football players' helmets, and they'll track which players have had concussions, and it's a very, very high-tech thing they're doing with concussions these days, but kind of the commonly reported force is 15 G's of force to cause a concussion. And we know mechanism of injury for concussion and whiplash are very similar. The only difference is where the energy is eventually distributed. Is it distributed through the head and into the brain, or is it distributed through the neck and some of the structures that hold up the head? So, several factors. Is 15 G's maybe what caused whiplash? I don't know, but when you get hit by a car going 60 and you're at a dead stop, you better believe you're going to get a whiplash. So this is a summary of the whiplash associated disorder classifications. It also lists some concussion symptoms that can manifest. So this is why these are so closely related. Whenever you're whipping the neck or brain back and forth, you're going to have neurological symptoms. So I want you guys to know these classifications and know some of the symptoms that are associated with each classification. It goes from 0 to 4, and 0 being the least injurious, and level 4 being the most injury, and symptom duration and that sort of thing. So the WOD classification of 0 is no neck complaints. The WOD classification is of level 1 would be a complaint of neck pain, stiffness, or tenderness. For level 2, they'd have neck complaint with musculoskeletal signs, maybe weakness or pain when turning their neck or decreased range of motion, etc. Level 3 would be neck complaint, musculoskeletal signs, and also neurological signs. And then a 4 would be the worst. That'd be a fracture and or dislocation. There are concussion symptoms that may manifest in any grade, and that's why there is a classification of 0, because even with no neck complaints, a patient could still sustain a concussion. So concussion symptoms that may manifest in any grade, you can look through these, and then other concussion symptoms as well. So make sure if you arrive to a scene of maybe you're randomly driving and you see someone get rear-ended and you're a first responder, just making sure everybody's okay, kind of assess the situation if they're having any neurological symptoms. So, force direction plays a significant role in the degree of damage sustained by the patient. We've kind of already touched on this. Read your Dutton book on force direction and implication on injury. They have a very, very good outline. I think it's page 1166, somewhere around there. It will go over a lot of the force direction stuff. As far as motor vehicle accidents and whiplash, there's some variables that may need further research, but as far as sex of the person, they've looked at women more than men, but women generally sit more forward than men in the seat, and that places their body closer to the front of the car, which may lead to more head contact with the dashboard and or steering wheel. Women's necks also are typically less strong, so if less force exerted onto that person could cause more damage than if that same force was exerted on a male who might be bigger, stronger neck. Seatbelts. Is there some controversy with seatbelts? Well, seatbelt, it stabilizes the trunk and acts as a fulcrum for force, which causes your head to lash. So some argue that seatbelts may increase the risk for whiplash and concussion. But when you look at the National Highway Traffic Safety Administration data, seatbelts significantly reduce mortality risk with car accidents. So would you rather have a whiplash injury or would you rather be dead? I think that's what it comes down to. And I think no one ever questions the use of seatbelts. They'd rather make sure that they're safe and their family's safe when driving. And then a headrest. This is actually pretty important. Whiplash is associated with headrests too low or too far back, and actually there's been cases where patients suffer internal decapitation through whiplash injuries because they might not have had a headrest on the back of their seat, so their head literally just keeps going backwards, which causes a fracture or upper cervical ligamentous instability. and creates death. So make sure you have a headrest and make sure it's positioned appropriately, not too low, not too far back, and definitely have one. Clinical findings, PT should perform an exam and an eval looking at both orthopedic and neurological findings. This includes upper motor neuron signs and symptoms, looking at periodic loss of consciousness, patient's willingness to move, painful weakness of the neck muscles. If gentle compression or distraction is painful, that could mean there's a fracture. If they have severe muscle spasms, any complaints of neurological problems. Again, Dutton, page 1166 and 1167, they list a bunch of sources, anatomical structures, and so on and so forth that might key you into some of these symptoms that are listed above. So I would look over that as well. That's all free game test material. So as far as imaging goes, what do they do when someone has this injury? Because you obviously want to rule out any sort of fractures or dislocations or things of that nature. So bottom right, you'll see that they've done a radiograph looking at both the patient inflection and extension. And then your guidelines of clinical practice for neck pain has suggested that they're now using some ultrasound. This person in the picture is actually getting ultrasound probably near the carotid artery. However, in the Whiplash, I think it'd be positioned more posteriorly to look at some of the structures such as multifidi and those sorts of things. The big thing that they're doing is high-resolution MRI, because this has the ability to demonstrate abnormal signal intensity, which could indicate tissue damage in both the alar and transverse ligaments in subjects with both chronic WOD and acute WOD. So this is important, and we want to make sure that if we get a patient in, their x-rays are cleared, and then we do this upper ligamentous testing and they get any of their signs or symptoms associated with positive tests, then we refer them back to the physician who may at that time order an MRI to confirm or deny those symptoms. Elliott et al. Demonstrated that female patients with persistent whiplash of a grade 2, so you guys should know the grading system now, we went over that, show MRI changes in the fat content of the cervical spine extensor musculature that were not present in subjects with just chronic insidious onset of neck pain or in healthy controls. So that's a bad thing. We see this in the rotator cuff as well. When there's an injury and a tear to something, a lot of times the muscle doesn't heal as well as we would hope. And what happens is there's atrophy to the muscle, and then there's fatty infiltration into the muscle. And as we know, adipose tissue is non-contractile, so now we have decreased strength, we have poor proprioception, we have a lot of things that go on that may kind of contribute to the chronicity of some of these neck pain patients. So fatty infiltration is a deleterious as it decreases the relative cross-sectional area of cervical spine multifidi. It's bad stuff, bad stuff. Imaging studies often fail to identify structural pathology related to symptoms in patients with whiplash injury. Because a lot of times they don't have fractures, and they're just dealing from ligamentous strain or ligamentous sprain or tendinous strain. However, emerging evidence into upper cervical ligamentous disruption, altered segmental motion, and muscular degeneration has been demonstrated with radiographs, ultrasound, and MRI. So what do? We get these patients in, and what do we do with them? Well, the clinician must rule out and have confirmation through imaging that there are no fractures, dislocations, intervertebral disc injury, or neurovascular compromise. I think that's fair to say. You want to be absolutely 100% sure that this patient is, intact physically, and you don't want to make things worse. Initial interventions that you can do with your patient, usually in the first couple of days once they've been seen by a physician or emergency medical personnel, they'll get a cervical collar, and this is just to reduce their muscle spasms and guarding. They're going to tell them to take it easy, be on bed rest for a few days with some muscle relaxants, try to decrease spasming. When they come and see you, however, the biggest thing is going to be patient education. You want to encourage movement. You want to begin some home exercise program encouraging not just head and neck movement, but also upper extremity movement. And you can work on neck muscle isometrics. Obviously, these will be submaximal, and then full range of motion has to be restored before you can start doing heavy strengthening. That includes with the upper extremities. I like this picture of this guy on the bottom right here. He's, he looks pretty happy, but the hardest thing that I've seen my patients is they have a hard time using the phone with the neck brace. So luckily there's a orthotic and prosthetic manufacturer that's come up with a solution for this. So now my patient's happy again. He can use the phone, and life is good. Moving on to some more progressive interventions here. Typically, patients are feeling better at around the 6 to 8 week mark. This is just due to normal healing tissue, and that's about the time it takes for some of those things to occur. But pain and headaches may persist for 3 months or more, and we know through some of the other studies we looked at earlier that this, basically head position and force direction can correlate to longer symptom duration. So hopefully by 3 months they're not experiencing too much pain, but we know it can happen. Once your patient has restored full, relatively pain-free neck range of motion, progress the following. You're going to do head and neck proprioception. There's some cool drills. I'll try to upload some videos to the course shell for this, involving a pen light, and then there's periscapular muscle strengthening. As you see in the picture in the top right, you want to work on multiplanar movements of the head and neck and upper extremities, throwing in upper extremity drivers, or changing kind of the direction of your driver. Have a head and neck driver, or have a torso driver where the head stays fixated on a position. You also can do stuff with vestibular therapy interventions, such as the vestibular ocular reflex. You can work on quick head movements, gaze fixation, etc. And that's pictured at the bottom right there, and more. And really, these patients just want to get back to normal way of life. So a lot of things you can do, you can try to relate to functional activities, even having them sitting on a stool and you pushing them in the clinic as they turn their head left and right, so they're getting multiple kind of neurological stimuli and input as they're in the clinic there. This is from a study in 2001 that was just looking at kind of what is the physical therapist role in the treatment of whiplash injuries. So they have some very, very generalized speaking phases here and sub-goals of whiplash treatment. So phase 1 is going to be 4 days or less. You want to reduce pain, and you want to increase the knowledge of and insight into the condition. So just like we talked about, interventions to decrease their symptoms, and then also patient education. Phase 2 lasts about till 3 weeks, and then you're going to try to improve their function. And then you can just see and read along in this chart of phase 3, and then phases 4, 5, and 6. We're just going to really try to improve their function, their level of activity, their participation in things, and then promote adequate coping strategies, which I don't know if I agree with coping strategy, but there's going to be times where your patient asks for your help, and maybe they need to cope for a few weeks until their symptoms decrease. As far as outcomes goes, these can be very tough cases. And a lot of these patients are in a lot of pain, and it takes a long time for it to come down. From your APTA clinical guidelines for neck pain, which you guys should have a copy of that. If not, email me, I'll send one to you. The clinical prognosis of patients with whiplash-associated disorder is less favorable. A survey of 108 patients with a history of whiplash requiring care at an emergency department found that 55% had residual pain and disability referable to the original accident at a mean follow-up of 17 years later. I mean, that's insane. Neck pain, radiating pain, and headache were the most common symptoms. 33% of the respondents with residual symptoms suffered from work disability, compared to 6% in the group of patients without residual disorders. So these are why these cases can become so tough. And this is also why patient education is so important. So a lot of these patients feel disabled following this, and that perpetuates on itself. And as you can see, there might be a little pain catastrophizing going on 17 years later. Recommendation from the clinical guidelines for neck pain. This is based on a level A evidence, which is the highest level of evidence. Their recommendation is to improve the recovery in patients with whiplash-associated disorder. Clinicians should, 1, educate the patient that early return to normal, non-provocative pre-accident activities is important, and 2, provide reassurance to the patient that good prognosis and full recovery commonly occurs. If we look at your impairment-based category, this also has your ICD-10 code, the symptoms, the impairment of body function, and intervention. You can see we've already touched on a lot of these things, but you can certainly pause it here and go through this chart. It's also in your clinical guidelines. I want to say thank you for your attention. I'll be happy to answer any questions you might have.